Hey guys, Jay here. So I just wanted to talk through a case, and I've got like 3 minutes to do so. This was a lady with whiplash after an RTA. It's pretty chronic. She's overall, it's fine. It's not irritable or anything, but she was getting some left-sided neck pain, kind of mostly around. She reported it kind of around this sort of upper trap, and then into the sort of posterior aspect, like posterior medial scap on that side. She returned to the gym and was noticing that reporting this complaint having come on during seated row exercise, and when we came to assess her, we broke it down, segmented, so we went through cervical spine. We screened the shoulders and scapulothoracic and then thoracic spine. Found that she had very limited, well, not very limited, partially limited, poor kind of quality and limitation on that left thoracic rotation compared to the right. It was very clean, good, not only range of motion but quality of motion as well. So we're suspecting then that there is potentially some kind of stability motor control deficit on that left thoracic rotation, because her passive range was there, we could get her there. Her available range was the same as the right, but actively she couldn't get there, and pain was a limiting factor there. Now it's important to remember that as well. This is a common pattern I find, is that when it comes to that painful spot around that back of the scap, is that there's often this assumption that it's kind of like a soft tissue, like, oh, you kind of just go into it's the muscle that's under that spot, so maybe it's rhomboid, maybe it's mid-trap, or whatever it may be. And I'm not saying that there aren't trigger points there and that isn't ever an issue, but with someone like this, where the history is they've had these neck issues and they've had the whiplash in her case, etc., etc. Remember that when it comes down to common pain pattern referrals, and think about sort of like our dermatomal regions as well, is the scap area is commonly like a lower cervical referred area, that kind of C6, C7, and I'll put a picture up there, a really useful one I got from physio tutors, big up physio tutors, to illustrate that. So what we kind of found is that with repositioning, particularly at her cervical spine, taking it out of that forward head posture, and upper thoracic extension, lower cervical slouch or flexion, got her out of that. We could do the same thing, it felt much better. Now we're not changing anything scap thoracic, or even we're changing a slight change to the length tension relationships. She's doing the same motion at shoulders, that's what I mean to say, but change that spinal position is kind of giving me a suggestion as to where to direct my treatment. And back in the past, I would have been like, let's go in and dive prematurely into soft tissue work and locally. But then we did some MOBs on her lower cervical, ipsilaterally, APs, and we did some really cool motor control drills, eccentrically decelerating that thoracic rotation to the left, which got way better, was much better afterwards. No mobility drills, because like we said, the hypothesis there is that it's a stability motor control deficit. The body is removing mobility to improve its sense of safety and security. Pain is an output there as well to stop it from going into that range. When we restore that stability authentically, the body doesn't need to put that handbrake on. It is convinced that your pedal brakes are good enough, so it starts to remove pain, take it away, the necessity for that's gone, and your range of motion starts to restore. So that's my little tip, and in perfect time.